It is with great pleasure that I introduce you to Dr. Selvan P, a distinguished leader and expert in the field of physical medicine and rehabilitation. Dr. Selvan serves as a professor in the Department of PMR at Government Medical College Trivandrum and holds the prestigious position of the Joint Secretary of IAPMR at national level and Vice President and President-elect of IAPMR Kerala chapter. He is also the organizing chairperson of this conference. Dr. Selvan's contributions to the field are vast and impactful. He is widely recognized for his leadership and expertise, particularly at the national level of our professional body. Many of you may remember his insightful webinar on obesity, where he shared valuable knowledge and strategies. Today, Dr. Selvan will be enlightening us on the topic of pharmacotherapy in pain. Please join me in welcoming Dr. Selvan P to the stage.
Respected chairpersons and dear friends, I will give an overview on pharmacotherapy of pain. My talk will include introduction, a few words about NSAID, Opioid Analgesics, Adjuvant Analgesics, Transdermal Analgesia, and continuous Infusion Analgesia. Pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue injury. Try to find out the reason for pain. Think about common conditions first. Constipation may be the reason for discomfort, especially in geriatric population. Hunger may be the reason for discomfort in children. We should think these conditions also. Doctor-patient relationship is of prime importance when considering the management of pain. Words have the potential to heal or to sicken. Right words can lead a patient to optimism. The practitioner should know the natural course of disease he is treating. Sometimes the person is suffering from contusion of shoulder without any muscle tear or a bone or no damage. Just local ice application is enough to, with sufficient reassurance to the patient is enough in the management of pain. On the other hand, the person is suffering from acute IVDP with a progressive neurological deficit. We should act immediately with all sort of weapons. We should also know about the pharmacological actions and toxicity, reason for choosing a particular drug, method to assessing the efficacy of the drug, and also should know the possible interactions when multiple or several drugs are administered concurrently. Drug should be prescribed only when there is a clear indication. The benefit to be expected outweigh the possible harm. Prescribe right drug to right patient in right dose by right route at the right time interval makes the physician acceptable. Pharmacotherapy in special population like geriatric patient, we should choose the ideal or optimum dose of NSAIDs and the suitable NSAIDs. As far as possible, avoid CNS depressants. Some geriatric patients are taking diuretics. Most of the NSAIDs will interact with these diuretics and can produce retention of fluid. So we should avoid such type of drugs. Then in pregnancy and lactation, drug absorption may be delayed due to increased gut motility by raised levels of progesterone or vomiting, and also in pregnancy GFR is increased, so the renal elimination can be more. NSAID can produce a constriction of the ductus arteriosus, necrotizing enterocolitis. Aspirin, if given in pregnancy, can increase gestation time, prolonged labor, postpartum hemorrhage, and bleeding in the neonates. Paracetamol in the usual dose is safe. We should regularly monitor for possible side effects, especially renal, hepatic. Rationale of drug management should be to reduce inflammation of injured tissue in nociceptive pain and reduce the excitability of a somatosensory system, the neuropathic pain. The pharmacotherapy should aim to treat the actual cause of pain or to symptomatic management of pain. I will stick on to the pharmacotherapy of pain in general because subsequent speakers will deal the specific management of individual conditions. Pain may be neuropathic or nociceptive, again somatic or visceral. Somatic pains are well localized, dull or aching, erect, arise from cutaneous or deep tissues. On the other hand, is poorly localized, deep, squeezing, pressure-like, associated with nausea, vomiting or sweating. Arise from organ infiltration, compression or stretching. On the other hand, neuropathic pains are severe, burning or shooting type, arise from traumatic or ischemic injury to system or central nervous system. 70% of the patient with advanced cancer will have pain. It may be caused by cancer itself or associated condition like osteoarthritis, pressure sores, surgery, metastasis, nerve compression or psychological reaction to the illness like depression or sense of helplessness. Analgesics are drugs selectively relieves pain by acting in the CNS or peripheral pain mechanism without significantly altering consciousness. They may be non-opioid like paracetamol, NSAIDs or opioids or maybe adjuvant drugs. Adjuvant analgesics are drugs used primarily for indications other than pain. They may be antidepressants like duloxetine, amitriptyline, anticonvulsants like pregabalin, gabapentin. These drugs are anticonvulsant drugs are the miracle drugs of this century because with the invention of this drug, the neuropathic pain can be very much managed. The pregabalin maximum dose is 450 milligram. Gabapentin, the dose is 1.8 to 3.6 gram per day. Alpha-2 agonists, they oppose the effects of sympathetic nervous system, ultimately decreasing smooth muscle contraction, like clonidine, tizanidine. Glucocorticoid, they will reduce inflammation and edema, thereby reduce pain. Local anesthetics, topical agents, NMDA receptor antagonist. NMDA D-aspartate receptor is a receptor of glutamate, the primary excitatory neurotransmitter in the human brain. Then cannabinoid, bisphosphonates and calcitonin. If the pain is due to osteoporosis, we should give bisphosphonates or calcitonin. Then GABA agonist. Before treating or starting management for pain, we should actually assess the severity of pain. Several scales are available. The symbol scale widely used was this visual analog scale. WHO Analgesic Ladder. It is a 3-step ladder. Start with step 1 if a mild pain, non-opioid paracetamol or NSAID plus adjuvant. If no relief, step 2 weak opioid with adjuvant. Again no relief. Step 3 strong opioid like morphine plus adjuvants. Revised WHO Analgesic Ladder includes one more step. There is a 4th step, which is interventional pain management in addition to the 3rd step. NSAID. Few words on NSAIDs. First line drug effective for mild pain. Have analgesic, antipyretic, anti-inflammatory action. They act primarily on peripheral pain mechanism. They inhibit formation of prostaglandin. Maybe COX-1 or COX-2 inhibition. But also act on CNS to raise pain threshold. Can be given orally, intramuscularly or topical application. Tissue injury causes local release of various mediators including prostaglandin. They cause hyperalgesia by sensitizing nerve ending. NSAIDs prevent these actions by stopping synthesis of prostaglandins. They are absorbed well from the gastrointestinal tract. With the chronic use, gastric irritation is a common side effect leading to erosion, ulceration, perforation. Proton pump inhibitors like pantoprazole, rabeprazole are very effective in preventing gastric side effects. But remember that these proton pump inhibitors are nephrotoxic in long run. Cautiously used in older age and history of gastrointestinal disease. Most of NSAIDs are nephrotoxic and hepatotoxic. These are the commonly used NSAIDs: aspirin, ibuprofen, pyroxicam, ketorolac, indomethacin, diclofenac, paracetamol, selective COX-2 inhibitors like celecoxib. Then newer NSAIDs like etoricoxib, etorolac, nabumetron, Pharmacotherapy. Pharmacotherapy is the last year invention. Then coming to opioid analgesics, morphine and other opioids exert their actions by interacting with the specific receptors present on neurons in the CNS and in peripheral tissues. Receptors are mu, kappa, delta. They generally cause neuronal inhibition by decreasing release of the junctional transmitter. Endogenous opioid peptides like endorphin, enkephalin, dynorphin, many events or stimuli that are experienced as a painful, stressful or traumatic can induce the release of endogenous opioid peptides. These peptides then act to make humans and animals less due to nauseous events by inducing euphoria and analgesia. Opioid analgesics are more effective for dull, poorly localized visceral pain than somatic, also for nociceptive pain than neuropathic pain. Opioid analgesics are not the first-line drug for neuropathic pain. The associated reactions to intense pain like apprehension, fear, autonomic effects are also dampened with opioid analgesic. The degree of analgesia increasing with the dose. High and repeated dose produce respiratory depression, sedation, vomiting, and tolerance, and can also produce dependence. Can be infused intrathecally or epidurally. Side effects are reduced and used extensively during labor, postoperative pain relief, and cancer-related pain with the epidural application. Opioid analgesics may be more agonist, antagonist, and partial agonist. For moderate pain, we can use codeine, tramadol. Strong pain with a short half-life, morphine, fentanyl. Strong pain for a long-time action, levorphenol are used. Morphine. Oral morphine is the gold standard for the treatment of cancer pain. Available in various strengths as tablet, both fast-acting. This is available 10, 20, 15 milligram tablet, and also for sustained release tablet and injection. There is no upper dose limit for morphine. The maximum safe dose is that which achieves suitable pain relief with acceptable side effects. Morphine was first isolated between 1803 and 1805 by a German pharmacist, Frederick Sertiner. Morphine was began to marketing commercially in 1827 by Merck. Sedation due to built-in protection. If the patient is self-administering, the patient will not be able to take the next dose. However, if a caregiver is administering the morphine, should take care. Then titration of oral morphine. First we should give an antiemetic, that is a metoclopramide 10 milligram. Then if the patient had no previous opioid, then start with the oral morphine 5 milligram. If the patient had a poor pain control while taking step 2 opioid, then start with the morphine 10 milligram. Start. Repeat morphine 5 milligram or 10 milligram every hour, eliciting a pain score before each dose. Monitor for drowsiness. Once pain well controlled or become drowsy, patient can go home with morphine 5 milligram or 10 milligram 4th hourly, and 5 milligram or 10 milligram SOS for severe pain. Then count the total dose of morphine required for a day to achieve pain-free status. Divide the total dose with the 6, will get the single dose strength. Then give it as a 4th hourly dose. What should be the aim to titrate oral morphine? We should achieve a good night's sleep, ability to mobilize, ability to carry out ADLs, return to some work. Then transdermal patches. NSAIDs are available as a transdermal patches, diclofenac 50, 100 milligram, ketoprofen 30 milligram. It should be applied once daily. Then lidocaine available as a 4%, 5% patches should be applied 3 times daily. And buprenorphine is very effective. A single patch can be used for up to 7 days, but it is costly, around 450 to 500 rupees. Then fentanyl patch is available, total 25, 50, 75 and 100 microgram. It should be changed every 3 days. Then a few words about patient controlled analgesia. Type of pain management that lets you decide when you will get a dose of pain medicine. This is especially important in case of cancer pain. With a patient controlled analgesia, you don't need to wait for a nurse. The commonly used drugs used in patient controlled analgesia are morphine, fentanyl, methadone. The suppositories, like if the patient is not taking oral medications and also other route of administration is difficult, then we can give suppositories like this paracetamol available as 125, 250, 500 milligram, 1000 milligram, and also diclofenac like 12.5, 25 and